Hi, everyone, all the members, participants. Good evening, good morning, wherever you are. And I'm now in Hong Kong, having this wonderful time to spend for the next 1.5 hours together with you. So my name is Dee Lee, the president-elect of the World Hepatitis Alliance. I'm so grateful that we finally had the opportunity for this year to talk about triple elimination. It's, I'm kind of I have to say that it's even a sexier topic than hepatitis itself. Because if you take a look at the participant now, it's, the numbers keep booming up. But what I can say is now that, I don't think 1.5 hours is good enough for us to share, but we try everything we can to make things happen, have more discussion, never shy of leaving your comment, your question in the chat box, or maybe in the Q&A section as well. So just have a small introduction of triple elimination. I don't think you guys need anything, but just for the future, that people needs to join to take a look at rewatch the webinar. So triple elimination of the vertical transmission, in short form, EVT, of HIV, syphilis, and hepatitis B will save thousands of lives each year. Triple elimination programs are also the key to achieving hepatitis elimination. By simplifying the access to testing the pregnant women, triple elimination enables timely intervention to prevent vertical transmission, the most common cause of chronic hepatitis B. It is also the gateway to family testing, ensuring that more people living with hepatitis B are diagnosed and linked to treatment and care. So as part of the World Hepatitis Testing Week, which is happening now, we are hosting this webinar to explore the critical role of triple elimination as part of the comprehensive hepatitis programs. It will discuss the different approaches to scaling up the EVT services and how different stakeholders can collectively work together to drive progress towards the elimination. So I am, a big thanks to the speakers who spend their time for this webinar. And before introducing them for the first session, I just want to let you know that the webinar is also being simultaneously translated into Spanish and French. The translation instruction will be shown on the screen. One of our speakers will speak in French today. So the other English speaker, you have to switch your tone, your translation language, into English. Thanks to our simultaneous interpreter as well. So we just launched a new advocacy briefing on elimination. The link to the briefing will be put in the chat. So also I want to thank Abbott as a supporter of the webinar. So following some sort of the very brief introduction for the first 5 minutes, I would like to have, I don't think any one of you are, a stranger to the next speaker, Fumi. So Fumi Lesi, the hepatitis team lead from the World Health Organization. And she is going to talk about the WHO's guideline for implementing the triple elimination programs. So please, Fumi, the floor is yours.
Right. Hello, everybody. Good afternoon, good evening, and thank you very much, Dee. And I'm very pleased to be part of this webinar on Viral Hepatitis Testing Week. And it's about scaling up hepatitis B within triple elimination programs. So I'll be representing WHO, and I thank World Hepatitis Alliance again. So next slide. So the global burden of viral hepatitis B is very well established. I think these are numbers that we all know. Over 250 million people living with chronic hepatitis B in 2022, And what is clear is that the burden is huge. The mortality is rising, and we're talking about mortality from liver cirrhosis and liver cancer. There's also about 1.2 new cases in 2022, and a lot of these new cases were childhood transmission and mother-to-child transmission. And hepatitis is really predominant in the Africa region and the Sahara region, despite the availability of vaccination and effective tools, but it's also significant in the Eastern Mediterranean region and the Western Pacific region, as shown on the map. And even we have cases in Europe and the regions of America. I will focus on two of our guidance documents developed by our hepatitis team in collaboration with global experts and organizations nationwide or globally in 2024 and 2025. And I will give an 8-minute snapshot to set the scene for the webinar. And I invite you all, using the scan code on the right of the screen, to see the burden of chronic hepatitis in your various countries. So we have this global repository for all countries and estimates. So next slide, please. So really, we have global targets that has been agreed by all member states for hepatitis B, PM, TCT, and triple elimination, as you would see on this slide. And as well, we have paths to elimination, and we're looking at important indicators for vaccination, for maternal testing, maternal treatment, and the vision is to reduce the incidence of chronic hepatitis B, and of course, the other two diseases in this endemic. Next slide, please. All right, so in 2024, WHO expanded the WHO treatment guidelines, and these increased the treatment eligibility to over 50% from the previous 8 to 15%. And some distinctive features of WHO guidelines, there are multiple guidelines, but it's only the WHO guidelines that really promote a public health approach with simple standard approaches, and these are targeting non-specialist care. We do know that other guidelines may target a specialized group, specific gastroenterologists, and models of care in high-income countries. So these new recommendations provide guidance for various assessment, who to treat, first-line treatment, and importantly, hepatitis B, PM, TCT. So there are 29 recommendations, 14 were new and updated, but because of the short time we have, I will just touch on 6 of the recommendations. So please, next slide. So on the next slide, these are the recommendations on antiviral prophylaxis among pregnant women and adolescent girls. And on the right, the recommendations in 2 different settings. The heart of the recommendation is to reduce new infections and ultimately reduce the incidence. And they are specific and graded. We have a strong recommendation in settings where DNA and e-antigen testing are available to begin prophylaxis. And we have a less strong, or should I put it as conditional recommendation in settings where there is no DNA or hepatitis B surface e-antigen testing available. And in these populations, prophylaxis with tenofovir is recommended for all who are hepatitis B positive pregnant women. On the right side of the slide, we have what to use to prophylax or treat. And again, we know these guidelines using tenofovir or entecavir, and the alternative therapy is using dual therapy and therefore synergies with the HIV program. Next slide, please. And the next slide, I want to use this slide to just highlight the evidence base. Understanding that WHO recommendations are strongly evidence-based, and the evidence for antiviral prophylaxis is pretty strong. However, I want to highlight that no studies really have examined the clinical impact and feasibility of the Prophylax All strategy. And I'm happy also to highlight the fact that right now we have 2 national programs that are working with universal prophylaxis. The first is in Malawi, and over the past 2 years, Malawi has tested more than 2 million pregnant women. And now efforts are being made to evaluate the impact of this. We also know that in the past month, Uganda has converted to this approach in view of the funding limitations that make it challenging for the country to afford viral load testing for pregnant women who are hepatitis B positive. The modeling shows, however, that this prophylaxis for all strategy is a potentially great strategy, and several millions of infants infections may be prevented with this. But in terms of cost effectiveness, it will vary according to the cost, the price, and the burden of the hepatitis infection. Next slide, please. And I'm going to rapidly go through. These are the last 2 recommendations I want to highlight, and we're looking at additional recommendations for testing. So we're looking at point-of-care DNA testing, which is a recommendation, and this approach called reflex hepatitis B DNA testing, which can be clinic-based or lab-based, and I know that speakers coming after me will really give us more information about the application of these 2 additional recommendations. Next slide, please. So the next slide is really moving to triple eliminations. What are the benefits? What is the rationale? And the rationale is clear, shown on this slide. There are so many synergies between the 3 diseases. It is an opportunity for integration, for person-centered care for that mother, because the mother is on the PMTCT platform. The 3 infections can be transmitted sexually. The 3 infections can be transmitted from mother to child. They have rapid testing. There are interventions for both mother and child. Now, on the right part of the screen is a new document, which is an implementation framework for triple elimination, which was launched this year, earlier in the year at the International AIDS Symposium. Next slide, please. And just what I want to share about this framework, it's really a revolutionary framework that allows us to think, to expand our thinking of PMTCT beyond merely looking at the pregnant woman, but looking at 4 pillars in the life course. So pillar 1 and pillar 2 focus on primary prevention and linkages to sexual and reproductive health. So that is the woman before she gets pregnant. Pillar 3 is about the pregnant woman in antenatal care, and pillar 4 is post-delivery. So it concerns the baby as well as the mother. Now, this innovative framework provides strategic planning guidance for countries, and it is kind of comprehensive, asking that we tailor actions to stakeholders across the 3 levels of care. Next slide, please. And therefore, in this hepatitis testing week, beyond testing for the mother of pillar 3, we need to also look at opportunities to scale up testing and care for triple elimination. In pillar 1 and 2, the first column shows us where these services can be delivered, and this can be in primary healthcare, it can be in other settings, it can be at the sexual and reproductive clinics, it can be at family planning, and it focuses on prevention. Preventing unwanted births certainly will prevent PMTCT. The pillar 3 are the opportunities within the PMTCT setting for testing, and pillar 4 includes testing even for the child after delivery of birth dose, and if they're doing post-vaccination serological testing. Next slide, please. And as I round up my quick discussion on the next slide, of course, key considerations for country action has to be discussed. It requires planning and organizing, and of course, the policy and guidance must be there. The challenges of timely birth dose, coordination, integration, community engagement, referral, and linkage to care are important. And of course, access. They need access to the rapid test kits, to referral, and then the monitoring and the evaluation of these programs. Next slide, please. And I think that's my last slide. And before I wrap up, I would like to just highlight some of the innovations and new steps, next steps, including the use of multiplex testing approaches that is going on in WHO now, and the recommendation to support countries to use these tests to reach more people. And then we have the new hepatitis B core-related antigen rapid diagnostic testing kit, which is coming to the market. And of course, we know our global funders who are supporting PMTCT in various regions. In the coming year, or by the end of this year, we are looking at an implementation guidance for hepatitis B and C recommendations throughout all the WHO guidelines. And final slide, I thank you very much for the opportunity to be here, and that's the scan code for some of the guidelines that may be helpful. So thank you very much, and over to you.
Thank you, Fumi. Wonderful speech, and a much clearer infrastructure for the next chapter for the EVT. So when I take a look at the numbers you show on the map, that can really stop people saying that they're doing such a good job in their own country in terms of hepatitis elimination, because at the moment such a simple thing and easy and economic way of doing the triple elimination. Not too many countries are doing a good job. But also want to take a look at the testing for the EMTCT can cross 4 pillars. This wonderful and also exciting thing to understand. That would be for our next chapter. But more or less, as Fumi said, working together is the ultimate and only way to have a effective triple elimination program delivery. Thank you so much, Fumi. And then our next guest would be Linda Kisaakye from the Ministry of Health, Uganda. Thank you so much. And she's going to give our presentation on improving access through POC, points of care, testing for the hepatitis B virus load. Thank you so much, Dr. Linda. The floor is yours.
Thank you, Dee Lee, and thank you Fumi for a very good start to the presentation. As they said, my presentation is going to be on the hepatitis B POC testing, a study that we did in Uganda, one of the parts of the guidelines for the WHO new guidelines. Next slide. Next slide. So this is my outline. I'll talk a bit about the triple elimination program in Uganda, and then I'll go into the study objectives, what we did, and then the findings and lessons and conclusion. Next slide. So like all different countries, our triple elimination strategy is hinged on the WHO guidance that Fumi has just shared. The fact that all the 3 diseases have a shared burden, they have significant impact on maternal and child health. There are high rates of transmission, and one increase has a synergistic impact on the other. So when there's HIV, then there are higher chances of hepatitis B and syphilis transmission, and vice versa. And also that there is easy diagnosis. There are rapid tests that we can use to easily diagnose, and prevention interventions exist for each of the 3 diseases. Secondly, this can be offered on the antenatal and postnatal platform. Timely interventions for the mother can prevent infections in children. Counseling and support for the partners and women is very critical. Safe delivery reduces the risk of transmission. It's important to follow up the infants, both HIV-exposed infants and those with the hepatitis B for birth dose and other vaccination. And then promoting infant feeding as well as lifelong care for the positive mother is very critical. Next slide. So this is speaking to the burden of hepatitis B in Uganda. Basically, our overall prevalence is about 4.3, about 1.4 in children, in women, so in pregnant women, and about 0.96 in children. And highest in some parts of the country. As you can see, the northern part of the country has a really high burden, and really where you find people of low socioeconomic status. And unfortunately, it's also the region with high HIV prevalence. That, you know, where the areas where you see the darker green, those are the ones with the higher burden. Next slide. So as a country, we've had a long journey of triple elimination, starting with the HIV PMTCT, which started in about 2000 in 5 pilot facilities. We scaled it up, and as we speak, early MTCT rates have reduced greatly to about 2.9, and end of breastfeeding transmission is about 6%. And vertical transmission still contributes about 14% of new infections. And we've reduced the new cases of HIV in children to less than 5,000. In 2016, we piloted the use of the HIV syphilis duo and started syphilis programming in the country, and rolled it up to all the facilities that were already implementing PMTCT of HIV. Infant vaccination started for hepatitis B, started with the pentavalent at around 2002. In 2014, hepatitis B was declared a disease of public health concern, and the government of Uganda allocated budget for hepatitis B screening and vaccination for adolescents and adults in general. In 2019, we launched the Free to Shine campaign, which started off the triple elimination implementation across all districts. And in 2022, we started the hepatitis B birth dose vaccination. However, we had a lot of challenges with the commodities. And finally, in September 2025, we were able to fully launch the hepatitis B birth dose and also get all the products. Our first triple elimination strategy was developed and disseminated in February 2020. And since then, the country has been implementing triple elimination as a whole. Next slide. So this is the framework on which our triple elimination is hinged, and that is the triple elimination plan that we developed in 2020. Majorly, triple elimination is integrated within maternal and child health settings, and all job aids and training is done on that platform. And we also have a section of PMTCT in the consolidated guidelines for HIV, for prevention and treatment of HIV. And those are our targets. We want 95% coverage for testing for HIV, syphilis, and hepatitis, and also reducing unmet need for family planning, and also ensuring retention in care for positive mothers and their exposed infants. Next slide. This is where we are as a country. You can see clearly we have not yet got there for hepatitis B. For HIV, the first buzz, we've been doing very well since 2020, over 90% testing, achieving 100% testing in 2024. Syphilis improved greatly once we introduced the dual test and is presently at about 95% testing. Hepatitis is still lagging a bit behind. We've only managed to reach 58% of the pregnant women. When it comes to treatment, maternal ART coverage for HIV is over 100. Syphilis treatment has risen to 90% by 2024, but we've only managed to treat 46% of women testing positive for hepatitis B. And hepatitis B third DPT3 is about 100%. We are only just starting to monitor our birth dose, and so the numbers are not really up there yet. Next slide. So going on to the study, our study was really to describe the operational characteristics and ease of use and the cost of utilizing GeneXpert machines for viral load for hepatitis B. And we compared it to the centralized conventional testing that we are using at the moment. So at the moment, all viral load for hepatitis B is done centrally using plasma. So we just wanted to see what is the ease of use, what is the cost in comparison. Next slide. So that was in the phase 1, we just wanted to make sure that the GeneXpert was in conformity with the Roche platform that we are using presently. And then in the phase 2, we described the operational characteristics and ease of use, and then the cost of utilization. Next slide. So phase 1 showed us that there was conformity of the GeneXpert. Sensitivity was 100% and specificity was 100% with a strong correlation. And this allowed us to then go into phase 2, where we're now just working at the GeneXpert sites. Next slide. So in phase 2, we went to 20 high volume facilities and recruited women who are coming for ANC. We screened them for hepatitis B and then put them into the study, and then did POC viral load on the GeneXpert facilities. We generally reached 259 pregnant women, 246 of who were eligible, 13 were not, either because they had already started hepatitis B treatment, or on confirmation, we actually found that they were hepatitis B negative. We then did clinical and laboratory matching for 123 pregnant women. Next slide. So these are the characteristics in general. I will majorly pass this. We concentrated on women who are at 24 weeks of gestation, because we know that's the time we start the actual treatment. We collected both clinical and laboratory data, and the women were screened at antenatal for all the 3 diseases, HIV, syphilis, and hepatitis B. And then we took off samples for the GeneXpert at those particular sites. All the facilities that we used had GeneXpert machines that were already multiplexing. Then for those women who had a viral load higher than 200,000, as the guidelines say, we started treatment and actually followed them up. So most of our women were within the age group of 20 to 29, as you can see. And many of them were either first or second pregnancy, and many of them were recruited between the first and the third antenatal visit. Next slide. So this is now looking at the turnaround time. We saw that there was a lot of improvement in the turnaround time for viral load results as compared to the standard of care. 96.7% of the samples were taken off and dispatched to the lab on the same day. 99% of results were processed on the same day in the lab as they were taken. However, there were few delays in the providers receiving results, even when they are processed at the facility, with only 77% of providers receiving results immediately after processing. So of the mothers, 61% of mothers received their results on the same day, and intervention was started immediately. A few of them could not wait because of the processing time, and about 27% came back for their results between 1 and 2 days. So in general, about 88% of mothers received care within 1 or 2 days. So there were few delays in result transmission from the lab because of the multiplexing issues. So the machine has to do HPV, hepatitis B viral load, EID, and viral load for HIV. So there's a bit of waiting time there. And then from the provider from the lab back to the provider, and then from the provider back to the mother. There were also a few delays leading to only the 88% of mothers getting care within 1 or 2 days. Next slide. So out of our mothers...
Sorry, Dr. Linda, we are a little bit behind the schedule. So can you just
I'm trying to hurry.
have a quickly presentation?
Yes.
So,
okay,
sorry about
that. Out of our mothers, 87% had a low or undetected viral load. 18% had undetected viral load, and about 69% had viral loads below 20,000. So only 12% had high viral load that needed to be tested. Next slide. Slide. And out of those, this is the cascade of linkage to care. Out of the 22 that needed that had a high viral load, 14 were started on prophylaxis immediately. Out of those 15, out of the 22, 15 delivered, and 11 of their babies had a birth dose given immediately. Next slide. With cost issues, we see that the cost is not very different between the conventional and the gene expert. But when you compare the issues of the patients getting timely results, then it really becomes cost effective. Next slide. Okay, I will jump this slide. It's just talking about what the health workers felt. And generally, many of them felt it was better. I will also skip that slide. Skip the slide. Let's skip that slide. Let's skip the slide. I think this can be shared so that we go to the conclusive slide. So in conclusion, there were a lot of positive attitudes among ANC teams that enabled a successful integration and linkage for mothers. There's high levels of motivation, especially when they are sure that their patients will get results immediately. Integration of hepatitis within the maternal and child health facilitated comprehensive care. Co-location of hepatitis services within antenatal and MCH was very made it easier for patients to get care. Costs of conventional and POC are comparable, but ultimately when you consider the costs of the mothers having to come back and maybe sometimes deliver before before the results come back, then POC becomes really cost effective. We also saw that community follow-up and community engagement about the available services was really supportive to ensure that the mothers actually utilize the service. I think this is my last slide. Next slide. Okay, thank you very much, and over back to you.
Thank you, Dr. Linda. I have millions of questions for you, but for the limitation of time, I have to invite Jessica, who is always the face of the for the World Hepatitis Alliance. She's going to share a very good program from the Alliance and working together with the other stakeholders, which is called the Safe Start Plus. The floor is yours, Jess.
Great, thank you so much, Dee. I'm so pleased to be here today and very excited to be speaking about our new program, Safe Start Plus, which is funded by UNITAID and a partnership between PATH, the international community of women living with HIV in Eastern Africa, and the World Hepatitis Alliance. So I feel like Dr. Linda and Funmi have done a really great job of already setting out why action is needed to accelerate the elimination of the vertical transmission of HIV, syphilis, and hepatitis B. But I do want to flag that this project also will cover Chagas disease in one of our core countries, Paraguay. And I also wanted to highlight just two things from this slide, and that is that the progress has been slow due to low awareness and demand, but also inequities caused by stigma, human rights issues, and harmful gender norms. And so through this project, we really hope to address all of these 5 barriers, but with real focus on these ones. And so Safe Start Plus is designed to really accelerate demand and adoption of approaches to delivery that are evidence-based and ground in community, to eliminate the vertical transmission of HIV, syphilis, hepatitis B, and Chagas disease. And the project has begun and runs through till the end of April 2029. So as part of the project, we have 4 different outputs. And the first of these is really around demand and adoption for elimination of vertical transmission interventions through strong community leadership and system strengthening. Output 2 really looks at evidence and learning generated through different models of care. And again, understanding how community, what suits community best for those models of care so that the models are responding to the needs of the community they're trying to reach. Output 3 is very much focused on strategic market shaping and unlocking barriers to new and underused essential products. And for the case of hepatitis B, what is particularly exciting is the multiplex test that Funmi mentioned earlier. And I think Dr. Linda showed really great data on how the dual test has dramatically increased testing rates of syphilis. And so it is really our hope that through this project, we'll be able to show the impact that multiplex testing could have on hepatitis B testing. And then finally, the final output is on effective transition and financing. So really ensuring that the findings are sustainable and scalable and go beyond just the Safe Start Plus countries, which I'm about to come to. But before I move on to the next slide, I really want to flag all of the logos that you can see on this slide, because this project is truly a collaboration between many partners working across many countries. And so while I'm discussing it today, I really am here on behalf of all of these partners that are going to be working incredibly hard and closely together over the next 3.5 years to really drive change. So these are our Safe Start Plus countries, and we have 4 core countries, which are Nigeria, Uganda, Malawi, and Paraguay. And in these countries, we're really looking at comprehensive support that covers across those 4 outputs that I just mentioned. Then we have a further 5 focus countries, and these are South Africa, the DRC, Brazil, Senegal, and Vietnam. And in these countries, we're really focusing targeted support to address a specific barrier related to EVT. And then finally, we have 10 peer countries, and I'm not going to read those out, but these countries were identified because they are countries where we can learn from them, but also where they can learn from us. And we are exploring, if your country is not listed here as one of the core focus or peer countries, we are really looking at how we can make sure that we share the learnings as widely as possible outside of these 19 countries. But what is really incredible about the Safe Start Plus project is that community engagement and leadership is truly at the heart of it. So it's being co-led by WHA and ICWEA. And together we will be managing the community aspects of this project. And those include a global and country community advisory boards, which I'll come to in a moment. But what I wanted to focus on this slide, and there is a lot of information on this slide, is what we'll be delivering through community grants. And these grants will be available in the core and focus countries. And these will really support community organizations to do a wide range of activities that will help ensure the success of the project, including, advocacy to ensure sustainable and ongoing access to EVT services, demand generation and awareness raising, addressing barriers to stigma and discrimination, ensuring that women feel empowered to speak for their communities. We'll be doing community-led monitoring, developing toolkits to support that, to ensure that the programs that are being delivered are truly delivering against what the community needs. There'll also be community-led service delivery, training for healthcare workers provided by community to ensure that the service delivery in community health centers is truly patient-centric. And then also looking at involvement on global validation advisory committees. So again, we want to ensure that community is embedded at every step of this project. And we believe that without that, the project will not be as impactful and successful as it could be. And so the community advisory boards, these really sit at the center of the project. They center lived experience and communities at the heart and ensure that all of the project, from research protocols to EVT, system delivery models, are designed with community in mind. And so we'll have a global community advisory board that will sit across the project and provide input into all aspects of the program. And then at the country level, in the 4 core countries, we will have community advisory boards, and these will consist of women with lived experience of the diseases, but also members of the community groups that support them. So the Global Community Advisory Board call for applications is now open. And so we do really encourage you to look at this. We would love to see passionate and experienced community leaders, in particular women, to apply for the program, to apply to be part of this and join us in shaping this really exciting program. So applications are going to close next Sunday. So please do make sure that you submit, and we'll put the link to apply in the chat as well, so you can get more information. You can also reach out to the Alliance or ICWEA if you have any questions or want more information about the Global Community Advisory Board. And then the country community advisory boards for Nigeria, Malawi, Paraguay, and Uganda will be opening soon. So if you are based in one of these countries, please do again consider applying. Dee, I see your face, so I know I'm running out of time. I have 2 more slides. So finally, I just want to touch on, as part of Safe Start Plus, we have partnered through the program between Unitate and Gavi to look at a Gavi-funded learning agenda for hepatitis B birth dose in Africa. And this is a really important piece of the project. It's evaluating delivery strategies to expand hepatitis B birth dose, especially outside of healthcare settings, which we know, for those of us who have been working in this space for a long time, is a real problem in terms of scaling up coverage. And so it's looking at innovative approaches like controlled temperature chain storage and community design delivery strategies, looking at how we can work with community health workers. And the outcomes of this will be actionable evidence to guide country adoption and scale up. So this work has already started. It's been ongoing in Ethiopia, the Gambia, Nigeria, and Uganda. And the idea is that the outcomes of this will help shape and support Safe Start Plus, but also other global partners in improving hepatitis B birth dose introduction planning. And we know a number of countries have recently had Gavi approval to introduce birth dose. So this is coming at an incredibly timely point in the discussion. And so country case studies and other key learning products will be published in December 2025. So we will disseminate that widely once available. And finally, the projected impact of this project. So this is what's really important. This project will save lives, it will prevent infections, and it will dramatically change the hepatitis, HIV, syphilis, and Chagas response for communities in these countries. So thank you very much.
Thank you, Jess. Now it's the panel discussion time. Due to the limitation of time, so I have to shrink this session a little bit. So please unmute yourself and also have your camera on, especially for Fumi, Dr. Kisaakye, and Jessica as well. So this panel is, we really wanted to talk about a couple of the very burning issues regarding to our sharing just now. So please use 30 seconds to 1 minute to talk about the following question I put in my heart for so long. So Dr. Fumi, do you think you have the any difficulties to work with the country that support the implementation of the guideline?
Thank you very much, and I will keep it short. As you know, WHO has a network. It has 6 regions. So we have regional offices. We have offices in over 120 countries around the world. And our role there is support countries, provide technical support, strategic support, policy support in implementing and adapting the WHO policies and global policies. So I think the short answer is absolutely correct. And right now, like you said, hepatitis B, PM, TCT, and triple elimination is trending around the world. So there's hardly any office that is really not working on triple elimination. However, we're trying to focus some of our work because of the recent restructuring and looking at country burdens. So we want to optimize our work, and focus on countries where there might be a significant burden of the 3 diseases as a first step towards reaching impact. So I'll stop right there. So thank you very much for the question.
Thank you, Dr. Fumi. The second question is to Kisaakye. So what is if there is only one, key learning for you to talk about with the other Ministry of Health, what would you say to them during your program, when you're facing with?
Okay.
Just one.
Okay, I would say something about integration with the maternal and child health services, ensuring that triple elimination is hinged on that, into the guidelines for mothers, into the SOPs, the data tools, and task shifting the testing of hepatitis to midwives. Because if it's left to the lab, then it remains hanging. So it is very, very important that if the countries want to scale up, they make sure that this is hinged on the maternal and child health platform, because then it also improves the hepatitis B birth dose. Hello, I tried to limit it to one since you said
sorry. Thank you so much. And also, I want you to answer the question that that is asked in the Q&A from Fatou. I think you're a much better person than anyone else at the moment. So can Hep B be cured? And can it be cured by the herbal medicine? This is question number 1 from Fatou. The second thing is, he and his wife are Hep B positive. Can they prevent their children from being affected? but you have more, authority to answer this question.
Okay.
Thank you.
I'm not an authority on herbals, so I don't know of any herbals that can be used to treat hepatitis B at the moment. All the treatment is lifelong, so people continue on treatment for the rest of their lives with a good monitoring. Most of them are okay. The second one, certainly yes, even when you're hepatitis B positive and your wife is hepatitis B positive, you can certainly have negative babies. If you attend, the mother attends antenatal and all the services are offered the way they are supposed to be offered. Testing, linkage to care, monitoring during pregnancy, immunization for the baby, including birth dose and the pentavalent, certainly the babies will come out negative for hepatitis B. And that's the reason for the triple elimination program.
Thank you so much. And Jessica, one question to you. What do you think the most relationship when we have to develop the partnership to increase the access to EBT services? Can you share some of the experience in the Safe Start Plus, please?
I think relationships and partnerships are absolutely critical. What is at the heart of Safe Start Plus is the collaboration between different stakeholders, whether that be Ministry of Health, implementing partners, academics, civil society organizations, but also across disease areas. And this actually goes beyond just the 4 diseases I mentioned. There is a fifth output, which I wasn't able to cover due to time, but that is focused on DRC, specifically on monkeypox, and looking at how monkeypox testing and care can be a priority for high-risk populations. So this project is constantly partnering and collaborating across stakeholders and across disease areas to improve outcomes for women and children. And I think that's what's critical, is if we put women and children central, then collaboration becomes the obvious step.
Thank you, Jess. And I saw you just answer the question online with the in the Q&A box. So before jumping into another session, it's time for the the live question as well. I saw one of the participants asked one to raise your hand already. So if you want to ask any question, do please raise your hand. So Ben, our king of admin, so he will just help to unmute you. So I'm gonna have the aspirants for you to unmute yourself to ask any question you want, please. Aspirants, you raise your hand. Never mind. So due to time limitation, I have to move on to the next. But I just want to thank, Karim, Jose, Matthias, Adam, Patrick, Richard, Henry, Kanadu, Dr. BC, Aaron. Well, you name it. Probably 20 or 30 of you guys saying hello, greetings. But you can do a lot more than that. Ask some questions. Please comment as well and raise your hand, because this webinar is not just for the Alliance and the speakers. So moving on to the next, though we very behind the schedule, but it's always a good thing for us to take a look at into the session by session. For the next session is addressing the barriers to elimination of vertical transmission of hepatitis B in Senegal. We are going to have a Fatou, Nguirane, if I pronounce it correctly. So the floor is yours. Veuillez commencer.
Voilà, merci beaucoup. Oh.
Vous pouvez y aller, Fatou.
Oui, vous avez désactivé la caméra, donc c'est bon?
Oui.
Oui.
Vous avez désactivé mon caméra. Donc là, je dis, nous avons fait un projet ici au niveau du Sénégal Et ce projet a permis vraiment de toucher une grande partie de la population. Donc, comme vous le voyez ici dans la présentation, si vous pouvez défiler pour moi, parce que j'utilise mon téléphone. Allô? Est-ce que vous m'entendez? Voilà. Donc là, vous avez vu que nous avons essayé de faire un projet et avec la prévalence qui touche près de 17% de la population. On a, avec la World Hepatitis Alliance, avec l'appui de Kedrion, on a fait, d'abord, on a lancé, on a fait la journée de lancement et ça nous a permis d'attirer l'attention des autorités comme le ministère de la Santé, les responsables du service du SMIT de FAN, les maires et les préfets, et ils nous ont supportés, en tout cas, pour dérouler ce projet. Donc, ici, vous savez qu'au niveau du Sénégal, des services de prévention de la transmission verticale mère-enfant sont en train de jouer un rôle révolutionnaire. On a eu la dose à la naissance depuis 2016, mais on a constaté que beaucoup de femmes n'avaient pas la conscience de respecter ces analyses pour pouvoir, en tout cas, sauver leurs enfants. Allô? Donc, c'est dans ce but qu'on a amené ce projet ici au Sénégal et on a pu dérouler beaucoup de... Est-ce que vous pouvez défiler pour moi? J'ai des soucis là avec mon ordi. Voilà, c'est bon maintenant. Donc, c'est dans ce but d'y remédier que l'association, en collaboration avec la World Hepatitis Alliance, a amené un projet dénommé « Prévenir les infections futures pour briser la chaîne de transmission du virus de l'hépatite B ». Ce projet vise à sensibiliser, à renforcer sur l'hépatite parmi les cibles clés. Bon, moi, je suis en train d'entendre la voix d'autres personnes. Est-ce que... Allô?
Oui, allez, Fatou.
Voilà, donc, merci beaucoup. Donc, désolé pour cette interruption. Donc, voilà, je disais qu'on a pu faire ce projet et que vous pouvez défiler en même temps, comme ça, je vais faire la présentation. Voilà, donc, je disais que le projet, et dans ce projet, il était question de le dérouler en 10 mois. Et on a sollicité les services du SMIT avec l'appui du docteur Aboubakar Sadikh Badiane, qui nous a permis de faire le plan d'action et nous accompagner dans les activités. Donc, auparavant, on avait fait des visites de plaidoyer qui nous ont permis de rencontrer le professeur Moussa Seydi, chef de service des maladies infectieuses et tropicales de FAN, le directeur de la lutte contre la maladie, Dr Mohamed Moustapha Diop, et la coordonnatrice du programme national de lutte contre les hépatites. Malheureusement, on l'a eu qu'en réunion via Zoom. Suite à ces visites, des séries de formations s'en sont suivies, à savoir le renforcement de capacité du personnel médical du district sanitaire de Guédiawaye. Et ce personnel médical a été formé par l'équipe du service des maladies infectieuses et tropicales. C'est un renforcement de capacité. On a réussi à former des membres de l'association SAAFARA Hépatites Sénégal et quelques volontaires de la banque de sang de l'hôpital principal de Dakar. Des journalistes et influenceurs, des acteurs communautaires et d'autres ont aussi eu des formations sur les hépatites et on leur a doté suffisamment d'informations pour en tout cas parler avec la communauté par rapport aux interventions, par rapport aux préventions. Des émissions radio communautaires et des causeries ont aussi été menées dans les zones de santé. Cela a permis, dans des postes de santé, et cela a permis une large diffusion des messages clés. Des journées de mobilisation sociale et de sensibilisation ont été organisées et l'une parmi elles a permis de recevoir le ministre de la Santé et de l'Hygiène publique. Donc là, on a, c'est à travers la SISDAC et c'est au moment où on fait l'étalage de la santé, des évolutions, en tout cas des stratégies et en tout cas tout ce qui se passe par rapport aux innovations de la santé. On en a profité pour recevoir le ministre et lui, en tout cas, faire part de nos difficultés par rapport aux hépatites. Donc, ce sont des journées on a organisé aussi des journées de mobilisation sociale et de sensibilisation qui ont été organisées et ces journées des journées de dépistage gratuit pour impliquer et de mise en lien avec les structures de soins agréées. En effet, avec ces journées de mobilisation sociale, on pouvait toucher toute une communauté et maintenant ces personnes vont aller transmettre les messages. On a fait des visites de plaidoyer ciblées qui ont aussi mené, que nous avons aussi mené auprès des commissions de santé de l'Assemblée nationale, auprès des élus locaux comme le préfet, les maires et différentes communes et auprès des leaders d'opinion afin de promouvoir un soutien politique accru et pérenne. Ces activités combinées visent à assurer un impact pour un changement de comportement et une adhérence à la prise en charge contre les hépatites, en particulier l'hépatite B, qui a vraiment un coût très élevé ici et qu'on doit revoir à la baisse. Donc, vous pouvez voir sur ces images les principaux participants. Et nous avons eu comme résultat du projet, nous avons eu à former 172 participants à travers des ateliers de formation et de renforcement de capacité, une large diffusion des informations relatives à l'hépatite B. On avait prévu plus de causeries. Malheureusement, on n'a pu dérouler que 52 causeries dans les 13 postes de santé que compte le district. Et on a pu toucher 1292 personnes, dont des femmes enceintes et un groupe cible pour encourager et faciliter l'administration rapide de la dose à la naissance contre l'hépatite B. 4 journées de mobilisation sociale ont rassemblé 466 participants et parmi les personnes dépistées, 27 sont revenues positives au VIH-B et 4 ont été efficacement orientées vers des soins. Là, on veut expliquer ici qu'il y avait 4 personnes qui avaient déjà commencé à faire la cirrhose et qu'il fallait rapidement prendre en charge. En plus de cela, 10 visites de plaidoyer auprès des parties prenantes clés participative pour sensibiliser et renforcer les connaissances et encourager la volonté politique nécessaire à l'amélioration de l'accès aux services de PTME et à l'administration de la dose à la naissance dans toutes les parties du Sénégal. Toutefois, le coût de la prise en charge reste élevé et des plaidoyers continuent d'être menés pour une accessibilité à tous de la prise en charge. À la fin du projet, un rapport a été établi et les détails du projet seront communiqués prochainement. Donc, pour cela, vous pouvez toujours joindre Jessica Hicks et Cynthia Kopouak avec qui on a travaillé. Et je voulais juste dire que c'est un projet qui a porté ses fruits dans la mesure où actuellement tout est revu. En tout cas, tout a changé. Et on a même eu un nouveau coordonnateur qui vient en tout cas faire ses promesses d'engagement.
Sorry, Dr. Fatou, can you speak up, please, because we are so behind. Thank you so much.
Thank you so much. Si vous pouvez fermer votre présentation.
Voilà, donc je dis, en fait, j'ai terminé par cette phrase. Je disais que le projet a porté ses fruits et qu'actuellement, ici au niveau du Sénégal, on est en train d'avancer. Merci beaucoup.
Thank you.
Thank you.
Dr. Fatou. And our next speaker will be Mohamed Salia, the founder and director and supporting the entrepreneurship and economic development in Sierra Leone. So thank you so much to share the topic on accelerating the access to tenatal testing for hepatitis B through No Hep Moms in the Country program. Thank you so much. You may start.
Yeah, thank you, Dee Lee, for having me, and thanks to the entire team at the Hepatitis World Alliance for having me on this very important presentation. It's great to be here to talk about accelerating access to maternal testing for Hep B through the Hep Moms program in Sierra Leone, which we are part of a grantee for implementing this project in Sierra Leone. So also thank you to Abbott, the donors, for your support. Next slide, please. Once again, I'm Mohamed Salia, the Executive Director for SEED Sierra Leone, community-based health advocacy organization. If you are not familiar with Sierra Leone, we have about 8 million population. So the brief chart you see in front of you gives you a national burden of hepatitis in Sierra Leone, which clearly indicates the urgency for addressing this matter. If you look at the first few boxes, indicates data from small studies, and which states health workers about 10% prevalence, non-HIV pregnant women 11%, blood donors 15.2, HIV positive pregnant 18.8, school children 16.7, school living with HIV 21.7, children 4 to 30 months 1.3, and the children 5 to 9 years 1.6. The second three data gives you a national representative of the current situation of Hep B prevalence in the country of 8 million population, which is 13.8, and HCV exposure or infection 2.4, and HCV infection is 0.5. So this gives you a picture of the urgency of addressing Hep B situation in Sierra Leone. Next slide, please. Next slide, please. Okay. So basically, these are some of the major challenges that have led to the first slide you see that's hampering antenatal testing from working on the front line in real time. One is competing health priorities and resources. The more reason why we are coming with this triple elimination, which is very important. There has been a lot of focus in Sierra Leone only on HIV/AIDS, malaria, especially this doing maternal mortality and outbreaks. This has been the focus of the government, excluding basically the hepatitis, especially during antenatal testing, and also low awareness among pregnant women. Many pregnant women have little knowledge about this. Sometimes they even say it's traditional, you know, and if they have symptoms of Hep B, they say it is traditional. And as a result of this, most of them are not attending even antenatal care. So these are also contributing factors, challenges. And another one is health workers' capacity. A lot of health workers in Sierra Leone, especially in rural communities, only have knowledge in HIV/AIDS, malaria testing, but not in Hep B. As a result, this has been very much neglected, which is leading to the rise in the situation. So another one also is weak laboratory and diagnostic capacity. There is shortage of test kits in many of the health facilities we are working with. They don't have the test kits, they don't have the capacity. The few we have is not enough. So this is also another one. And the one is the geographical setting, which is also a barrier. Despite the free maternity care, I can tell you that access to this care, some of the PHUs, the peripheral health units, are really far away. And even to come to the government hospital is also a challenge. Yes, next slide, please. Next slide, please. So with the help of the No Helps Moms in-country program, what have we been doing in Sierra Leone, specifically in both districts, the southern province, in order to help scale up the testing? Next slide, please. Next slide, please. Next slide, please. Yeah. So the first thing we have done so far with our action is assessing the knowledge level of these nurses. There we have noticed that they don't have the knowledge in this testing based on WHO. When women attend, they only test for, like I said, for HIV/AIDS, syphilis, but not hepatitis. And secondly, after this, we have also conducted training in partnership with the Ministry of Health. As you know, partnership is the only way out to address the situation of putting down hepatitis. So with the partnership with Ministry of Health, the Department of Hepatitis program, which has just been recently launched, we have conducted training for healthcare facilities to enhance their skills and knowledge, especially in Hepatitis testing for antenatal care women. We have built their capacity. Yes, next slide, please. Yes, we are also conducting community level education so that process. A lot of PHUs, peripheral health units, who were not able to be part of our program. As we speak currently, our team is in the field. As you know, this is the testing week. We are in the field also engaging these clinics and also pregnant women to tell them about the impact of these hepatitis and why, and also counseling processes, not only the testing. We are also preparing already the nurses that we have trained for the next batch of drugs of testing kits we'll be having from the ministry. And also these are some of the health facilities we are also targeting. Next phase, please. Next slide, please. Next slide, please. Okay. So these are some of the beneficiaries from the health facilities. If you see, the first person is Dr. Francis. This is his first time also attending the training in this testing process for his health facilities. We train all his nurses with the help of the Ministry of Health in Sierra Leone. So this is Dr. Francis, who is also given an acknowledgement of the training. This is also another state registered nurse, Kumba, who is also giving an acknowledgement of the training they have received for the first time ever in the whole region, like this. So these are the participants. Yes, next slide, please. Next slide, please. Hello? Hello? Hello?
Hi, Mohamed, we can hear you. I think there is just a slight delay because we moved the slides as quickly as you ask, so it just takes a bit of time.
Okay. So as the testing week goes on, we are having some of the partners we are working with have launched their first process of testing. They have also launched their first process of engaging pregnant women doing antenatal around these particular Hep B. If you can see from there, the Dase Hospital has first launched that, and this is the first of its kind. Interestingly to say, because like I said in the beginning, that most of the tests they have been conducting, most of the antenatal checkups that these women are coming, they are only coming for checkups for HIV/AIDS, for syphilis, for malaria, excluding this fee. And I can tell you an incident that I also share with the World Alliance at some point. There was even some test kits which came. They remain at the central until they got expired, because most of these PHU were not going for these test kits. They were not collecting it because they were not trained. For the first time, we have created linkages now that the next batch of test kits that will be around, they will be there to collect them. We have already registered their name with the ministry, and they have agreed that, yeah, of course, they will be supplying them immediately they arrive. So this is very important material will not get expired. The next slide, please. Yeah, so we are in the national newspaper for this first set of training we have conducted ever in the Southern region. Yes, so the last slide, please. Yeah, okay. Yeah, last one. We just spoke about this. Okay. Okay, okay. So thank you very much. And we also want to thank the Abbott for supporting this project. I'm sorry I have to run through it very fast because we are against time. And during the question period, I'll be able to hit the other things. Thank you so much. It's a pleasure to speak to you again. And we feel very empowered for these little webinars. Thank you.
Thank you so much, Dr. Mohamed. Please stay because this question is directly to you. Zymnet, so he asked, I'm currently working in Kenya, 40 minutes away from Bo, just seeing what does, and we have planned program here in Kenya for hepatitis awareness. He wants you to share your number with him. Obviously, this is not the scenario for you to share your personal information, contact with anyone here. You can do it later, whatever. But, you know, if someone, you know, who really needs to reach you out to say, I need support, what would you do to, let's say, in the long distance or short distance, you can provide more support to the other community members?
So first of all, we are trying to strengthen the referral pathways to get a testing kit inside those communities. Because most of these communities, I tell you, they are island communities where they have peripheral health units. Even drugs to get there is a challenging thing. And so some of them, they are not aware. So what we are trying to do, we have established the first contact with the Ministry of Health Hepatitis Program. Now we have set all of these facilities. We have opened a WhatsApp page where we update them when these test kits arrive. So they know that, hey, test kits A have arrived today, and we are getting these test kits to these communities. So we are also supporting to get the test kits there. So it is already there, and there we are offering also the training. Yeah.
Thank you very much. And let's jump into the group discussion, especially from the audience. If you, as I said, if you have any question, raise your hand. Ben in the back end, we will help you to unmute yourself. And it's time for you to ask your precious question and using this opportunity, especially the practitioners all around the world, and also the through me, she's been very busy, but still she take this time instead to jump into our conversation. So I just want to read out, Nishi. It would be much better if you ask in person, but I want to read your question on POC. The lab-based result will be recorded directly from the platform. How do you record the POC result from the community? Please provide guidance for recording the POC result, and how are the results sent to patient? I think, do you have any anyone you want to address to this question? Anyone you want specifically to answer this question? If not, anyone from as our speakers can answer this question on how do we record the POC result and send to the patients. Now, Jessica?
If Dr. Linda's there, it'd be great to hear how they're doing it in Uganda in terms of giving results to patients and doing point of care testing in the community. So Dr. Linda, are you still there?
Yes, I'm still there.
Great.
So the point of care study that we did was actually at facility level. And so we were giving the results to the patients during antenatal as part of the antenatal care package. And the results were already, we were doing it on the Gene Expert platform. So they were coming as part of the lab expert information systems. And they would come directly to the clinician. They would be entered directly into the machine and then brought to the clinician who would provide the results back to the patient during antenatal care. So we have not yet done a community POC testing, but we have done community hepatitis B testing. And for that, because we use the rapid tests, we give results, as we test. I think that's what I can say.
So in my opinion, that using the DBS is even better to do the lab test. Is that what we're trying to address here to Nishi for her question? Can I say that would be the most prompt response to Nishi? Dr. Linda? Yeah, never mind. I think again, raise your hand if you can. But I have my own question to our dearest speakers down here. It's about stigma discrimination. I'm sorry, I am a stigma and discrimination dude all in my life in the hepatitis sector. When we talk about the triple elimination, we heard from the communities saying that if we just wanted to go to the, especially for the rural area and the villages, anywhere that's suitable for the triple elimination in such a low cost and successful programs, stigma discrimination is one of the things that put in front of them to enhance or maybe implement this program. Imagine a woman would not, go away without, having the shame or maybe the stigmatization of being a person being, with 3 diseases at the same time. So can any one of you just tell me that how did you tackle these issues on stigma discrimination when you implement the project in the communities? Because everyone will be very, okay, if I am a person engaged with this, EBT, people will say that I'm a person living with these 3 different diseases. That's what happened most of the time. So
Hello.
I think, for Dr. Fatou, raise a hand. Can you elaborate your question in a very short, period of time? Thank you so much. Dr. Fatou. You may start. You may unmute yourself.
Voilà, merci beaucoup. En fait, moi, je me suis impliquée dans cet aspect de la triple élimination. Et vous savez, la stigmatisation, elle est très forte ici au niveau du Sénégal. Et pour ceux qui sont porteurs du virus, par exemple, du VIH ou bien de l'hépatite B, il y a des structures où ces gens doivent aller se faire prendre en charge. Et là, maintenant, on est en train de faire une intégration pour pouvoir changer cet aspect et de trouver, par exemple, un médecin pour toutes ces maladies afin de vraiment lutter contre cette stigmatisation. Donc, on est dans l'élaboration du plan stratégique intégré. On l'a démarré et on va le terminer d'ici le 28, Inch'Allah. Et là, nous luttons fortement par rapport à ça parce qu'ici au Sénégal, la stigmatisation, elle est très, très forte. Maintenant, j'ai un problème avec la traduction, ça va, ça se coupe, etc. Et c'est ce qui fait que j'ai du mal à comprendre exactement les questions, mais je pense que ça doit être ça la question.
Okay. Thank you, Dr. Fatou, for the short and in neat, question. Sorry, response for that. So I'm gonna give the mic to Matthias. Please ask your question.
Hello, I'm
Can I make
Matthias.
a quick? Okay.
Hello. Hello.
Matthias, I can hear you if you are the
Yes,
one.
I'm Matthias from Tanzania, working on hepatitis B, HIV, CV. My question is actually not a question, but a recommendation and suggestion. We have been speaking of people living with HIV, I mean hepatitis B, for the case of hepatitis B, testing them, linking them to treatment, but we are forgetting the negative ones. And these are the future hepatitis B positive potential. So my suggestion to WHO, Professor Lesi, if you can incorporate encouraging vaccination to those who test negative for hepatitis B infection, we can reduce the number of or the population which is vulnerable to hepatitis B infection, and therefore the future burden of hepatitis B infected individuals, and therefore the liver cirrhosis and the carcinoma. If we put it into the agenda as we speak of testing, treating, vaccinating children, birth dose, infantile vaccination. But I've never been hearing about adult hepatitis B vaccination. And these are the potential vulnerable individuals, also future hepatitis positive individuals.
Matthias, I have to cut you off a little bit, but I want, Dr. Funmi to respond this question if she's still available. Funmi, can you, respond to this wonderful, I think in my opinion, very interesting and useful question from the community?
I'm sorry, yes. Can you tell me what the question is, please?
The question is,
on the chat.
The question is, can we focus more on the issue if we, speaking of the encourage the adult for the vaccination, if the WHO can incorporate this into its goal, we can facilitate furthermore with the elimination by reducing the cost of the HPV in population.
I am not sure exactly what the question is, but I want to assure everyone that the focus is not on the hepatitis B negative individual. The focus is on the hepatitis B positive individual. The recommendations I showed us was about prophylaxis for hepatitis B positive mothers. It's all about B positive. So I wasn't sure what the question was. It's not a focus on B negative. However, in some countries, they focus on B negative. In some high-income countries, there's a recommendation to screen and vaccinate B negative. But the context, you must look at the context and you must look at the priorities. Sorry, it's about priorities. The hepatitis B negative, we know that adult conversion to chronic infection is less than 5% compared to over 90% chronic rate in newborns. So if we look at priorities, our priorities are those who are positive. So I might have missed some of the discussions, but please flag for me where we need to go. There are no recommendations for prophylaxis in hepatitis B negative persons. However, the birth dose is recommended to be universal. That is for all newborns within 24 hours of birth, irrespective of the maternal status. And that is an approach to reduce incidence. So maybe the question is unclear, but I'm on standby to respond. So thank you, Anova. I know there's a short time.
No, for me, your response is absolutely accurate and totally can echo to the confusion from time to time from the community. I just want to thank you so much to take up this time to clarify a little bit on triple elimination. So our last question to Richard, please unmute yourself and speak. Richard, are you still here?
I'm here. Good afternoon, good evening, good morning. Sorry, we have been in the field. Mine is a question. We have been in the field during this testing week, and the question was strong concerning a pregnant woman that positive in hepatitis B, and what are the treatments over their issue. That is one question. The number two is that we have been in the field, and a child of 5 to 6 years is being affected with hepatitis B. So I don't know how are we going to tackle it for them, for the medications to be given to them. Thank you.
Thank you so much, Richard. Has anyone, have 30 seconds to have a prompt reply to Richard?
Yeah. Can I?
Yes,
can
please.
I just talk a little bit? Yeah. Hello. Do you get me?
Who is speaking now?
Get me? Is it okay?
Yes, it's okay.
Yeah, I think that is why when we started, really, we said the most important alliance to defeat Hep B is partnership and collaboration. It's very important at grassroots level to also focus on working with the ministry. This can all really help with referrals and other essential support services. And for discrimination, for example, we at grassroots level should not forget that in our work, we should also produce jingles, in local languages, made on community radio stations to educate the community around this particular disease and also around discrimination.
Sorry, Matthias.
So jingles.
Matthias, sorry, I still need to cut you off because we are now still in the process to respond to Richard about the testing week and things like that. So thank you so much for your contribution. We can still keep this conversation going on for the whole discussion, especially for the next webinar. If in my opinion, for the testing week, Richard, you can go to the testing week webpage to see what you need to know, and throw any question to the email. And we have we have the whole team to be there to serve you for any question you wanted to, or maybe anything you want to do the testing week. I have to say, I have to end this, in my opinion, very, very, welcome topic in hepatitis sector. So thanks. I want to thank all the speakers and audience and join for this wonderful session. Advocacy briefing on triple elimination. Once again, this advertisement time. The link to the briefing will be put in the chat, or maybe you can jump into the World Hepatitis Alliance website. So I'm so sorry. I don't think this is going to be the end for the triple elimination. Let's keep this topic continue. Thank you so much for joining the session, and we'll see you next time. My name is Dee Lee, President-elect for the World Hepatitis Alliance. Thank you so much.